right, we're going to go ahead and get started. Welcome, everyone. We're excited to welcome you to the final program in our Spring 2024 Navigating Dementia educational series. My name is Diane Martin, and I'm an associate professor of gerontology at the University of Maryland, Baltimore, where I also direct our geriatrics and gerontology education and research program we call GGEAR. GGEAR developed the Navigating Dementia educational series as a sequence of 5 webinars and 2 in-person conferences designed to educate professionals and care partners of older adults and their families about Alzheimer's disease and related dementias. This series is funded by a generous grant from the Maryland Department of Aging, whose vision it is to change the trajectory of aging. The series has been designed and made possible by the efforts of our talented team of GGEAR associates, including Dr. Min Park, who's served as the research associate on the project for the past 6 months, our consultant, Ms. Laura Gillen, our research interns, Ms. Sabrina Amaral and Ms. Sharniza Balware, our coordinator that we couldn't work without, Justine Golden, and our newest GRA to the project, Mr. Alfred Boichi. The program booklet that you've received earlier this week via email provides valuable information and resources related to today's program. A reminder that the program is being video recorded, and the video from today's program and all programs related to our Navigating Dementia educational series will be available for viewing later this summer on the GGEAR Programs On Demand Library and also on the University of Maryland, Baltimore's Lifelong Learning Institute. And we expect to start uploading the videos and resources by the end of next week. A few housekeeping items. Let's see, we talked about the survey. If you're just logging in now, Min, please drop in that survey one more time. If you haven't already completed it, please do so now. Reminder, if you're here for continuing education credits, you must be present for the entire webinar and complete the post-conference survey and evaluation. If you don't remember your unique ID number, please email Min or Alfred, and their email addresses are in the chat box. We do receive an attendee list for Zoom after the program closes. Only people who are on that list can receive CEUs or a certificate of attendance. So if you're logged in using a link that was shared by a friend or a coworker and you need one of these certificates, please send me an email. I'll put my email address in the chat box in a couple of minutes, and I will send you a link that is unique to you for registration. The chat feature we're going to disable for comments during the program. I want you to please post your questions in the Q&A box, and I'll ask the questions to the presenter on your behalf during the Q&A portion of the program following each presentation. So let's begin. The objective of today's program, titled Empowering Caregivers, the Essential Resources and Supports in Maryland, are to identify Maryland's supports and services designed to promote optimal health outcomes, along with greater independence, better quality of life, choice, and autonomy, and to evaluate and access useful features of the GUIDE model, which you'll learn more about shortly. This is a comprehensive package of care coordination and care management, caregiver education and support, as well as respite services. It is now my pleasure to welcome back Amanda DiStefano, who presented as a panelist during our April 24th webinar regarding resources to support older adults in Maryland. Today, she will share a little more about these, as well as information about services and supports available to caregivers of persons living with a dementia such as Alzheimer's disease. Ms. DiStefano's complete bio is in your program booklet. She is the director of long-term service of the Long-Term Care Services Division within the Maryland Department of Aging. And please join me in welcoming Amanda DiStefano.
Thank you, Diane, for having me. I'm really excited to be here. Can everybody hear me okay? Doing a quick mic check. Okay, wonderful. Again, thanks for having me. My name, as Diane said, is Amanda DiStefano. I am the Long-Term Services Division Director here at the Maryland Department of Aging. I've been with the department for a little over 3 years now, and prior to that, I worked in our local area agency on aging network, and served as the outreach and education program manager and oversaw Maryland Access Point, which I talked a little bit before when I served as a panelist. Today's presentation will review some of the things that we've touched on very briefly during the panel discussion and go a little more in depth and hopefully answer some of the questions that you might have. A lot of the things we're going to talk about during today's session will also be referenced in your program booklet as well. So I'm going to go ahead and get started. I always like to start my presentations by sharing some information about the Maryland Department of Aging. I feel like a lot of times our department is a lesser known department because we're very small. Our mission at the Maryland Department of Aging is to prepare for the growing population of older adults by developing innovative approaches to aging, advancing multi-sector collaboration, and providing equitable access to resources. The aging population in our state and across our nation is growing exponentially, and our role is to really prepare and position Maryland to better serve the older adult population and really change the way that we as a state and we as a society ultimately think about aging. Our vision.
I'm
Yes.
sorry to interrupt you. You're not in presenter mode, so we're only seeing a portion of your slide.
Oh, interesting. My apologies. It's in presenter mode on my screen, so I'm not sure what you're seeing. So let me just.
I think you need to share. When you go into the share, there's probably a couple options. One is your notes page, which is on your screen, and one should be slideshow presentation.
My apologies. Is that better? Okay, wonderful. Always a technical glitch. My apologies. So anyway, our vision at the Maryland Department of Aging is to transform institutions, systems, and norms so all older adults lead lives that are healthy, financially secure, socially connected, and purposeful, which is a really grandiose idea, right? So leading lives that are healthy, financially secure, socially connected, and purposeful takes a village to accomplish that role. And one of the things that we rely on most heavily to achieve that goal are family caregivers. We are in the business of supporting and serving older adults, as well as individuals living with disabilities, their families and caregivers, as well as providers across our state. We oftentimes work with local community-based organizations and other providers and provide information about the resources, services, and supports that exist in Maryland. We forgot, there we go, okay. The objective of today's presentation is to provide an overview and information on accessing Maryland's person-centered family caregiver supports and services that are designed to promote optimal health outcomes, support independence, and improve quality of life. Family caregivers, as you well know, support others with tasks of daily living. When we say the word family, we oftentimes envision individuals who are related by blood, but family, of course, as we all know, is so much broader than that. It can be a friend or a chosen family member that's also coming alongside of an individual to provide support to help them reach the life that they want, to help them remain active, independent, and in the community for life. There are various terms that are used to describe family caregivers, like family care partners, unpaid caregivers, or even informal caregivers. We tend to use that word, informal caregiver, quite frequently at the state level in many of our program requirements or eligibility determination language. So I just want everybody to understand when somebody says informal caregiver, we are referring to a family caregiver as well. I want to just share some very brief stats. In our nation, approximately 43.5 million individuals are providing unpaid care. 34.2 million Americans have provided unpaid care to an individual over the age of 60. Most caregivers, around 82%, are caring for at least one adult, while as many as 3% are caring for up to 3 or more individuals. Approximately 15.7 million adult family caregivers are providing care to individuals who are living with Alzheimer's or dementia. The cost of caregiving is really heavy. Family caregivers spend on average 24.4 hours per week providing care, and nearly 1 in 4 caregivers spend more than 40 hours a week providing care to a loved one. the value of service provided by informal caregivers has increased exponentially over the last decade. And it's estimated that $12.5 billion is the economic value of this care that's being provided. So these are savings, $12.5 billion in savings passed on to the government and or Medicaid that would be potentially paying for other services to come alongside of individuals and provide that support, or an institutionalized care setting that would be providing care for these individuals. It's estimated in total, 1 in 4 adults are providing some form of care. If you're not currently a caregiver, at some point in your life, you will likely be a caregiver or need a caregiver. This is a topic that touches everyone. Why does this matter? Well, here at the Maryland Department of Aging, our overarching goal is to keep people active, independent, and in the community for life. And we can't do that without family caregivers. Family caregivers help us to achieve that goal. So we recognize the importance of family caregivers and the role that they're playing in helping coming alongside of individuals to support them. Maryland Department of Aging strives to provide person-centered services and supports that puts the goals of the individual first. Many of you are helping individuals do just that, reaching their goal of living actively in the community. I would venture to say that no one on this call today has ever set a goal of living in a skilled nursing facility. So our role, in our role, we really strive to improve health outcomes, quality of life for all providers and family caregivers and individuals that we serve, to reduce the need of institutionalized care. Family caregivers are a vital part of the care team in Maryland that help individuals remain safely in the community for as long as possible. We recognize the importance of this role and make it a priority to support caregivers in doing this important work. So let's explore the programs that are available to help in the state of Maryland and support caregivers who are providing all this wonderful work. Many of you have heard of, and if you've reviewed the program booklet for today, you read about the National Family Caregiver Support Program. National Family Caregiver Support Program provides grants to states to fund various supports that help families and informal caregivers provide care to older adults in their homes for as long as possible through the Older Americans Act. Older Americans Act are federal funds that come to states to support in this way. Some of the supports that are available through the National Family Caregiver Support Program are information about available services, assistance in gaining access to the available services, individualized counseling, organization of support groups and caregiver training, as well as respite care and supplemental services. So for the remainder of the presentation, under these categories and how to best access them. One of the best ways that you can gain access to information and assistance here in the state of Maryland is through Maryland Access Point. As I said, I already shared a little bit about Maryland Access Point in our last presentation. Just as a quick review, in the state of Maryland, Maryland Access Point serves as our network of aging and disabilities resource centers. There are aging and disabilities resource centers, or MAP sites, in every county across our state, serving our entire state population. And they provide a lot of really wonderful info. Being person-centered, which means it puts the person at the center of everything that it does. Maryland Access, by reaching out to Maryland Access Point, you can gain information around financial benefits and assistance that you may be eligible for, or your loved one may be eligible for, to help put more money back in their pocket to offset the cost of additional care to come alongside and support you. Through Maryland Access Point, you can learn about personal care services that might be available through either the Area Agency on Aging network services, through Older American Act services, or even through the National Family Caregiver Support Program. as well as other community-based services that exist in each of our counties across the state. Each of our Maryland Access Point offices are slightly different because the resources that exist in each community are slightly different. So I can't necessarily drill down and tell you every resource that's going to exist in every community across our state in this one hour presentation. If you are unsure about the resources that exist, Maryland Access Point is your entry point to learn about all of these different resources. As an example, Maryland Access Point staff can help with gaining information around food resources and connect you to the Supplemental Nutrition Assistance Program, SNAP, to help put, again, more money back in your pocket or in your loved one's pocket to help offset the cost of care. There are health and wellness programs that they can refer you or point you in the right direction of. MAP offices can connect you with transportation, social engagement opportunities, employment, Medicaid waiver programs and services, which we'll talk a little bit more about in just a moment, legal assistance, elder abuse prevention and advocacy, understanding Medicare. We'll talk about the SHIP program a little bit more in just a moment. Housing, a senior assisted living, guardianship, long-term care ombudsman program, veterans benefits, durable medical equipment, assistive technology, the senior college program, advanced care planning assistance, and so much more. This is not an exhaustive list. Our MAP really are meant to help connect you to the wide array of long-term services and supports that exist in the state of Maryland. I always like to share that MAP, you would go to a cardiologist for everything heart health. You would go to your pharmacist for everything about your medications. Maryland Access Point is your go-to for everything related to long-term services and supports, as well as community supports that can come alongside and help you reach your goal of living in the community, active, safe, independent for life. As I said, there are MAP sites across our entire state. There are 23 local offices serving all of Maryland's counties. They're typically embedded in area agencies on aging and have satellite sites in many of our senior centers across the state. They partner very closely with the Centers for Independent Living that serve in their jurisdiction, as well as the local health departments. You can see the contact number for the MAP office in your county. You can also reach out to MAP using the toll-free number. There is an 800 number associated with MAP, which is 1-844-627-5465. That particular number, our toll-free number, we call MAP Link here in the state of Maryland. It's to provide simple information and assistance 24 hours a day, 7 days a week. It is that line is answered by 211. And 211 is another really great resource for getting information in our state as it relates to services and supports. Oftentimes, if you're looking for very drilled down resources or need specific information about community resources to address the needs of your loved one or even your family caregiver needs, that 211 will oftentimes refer to the local office. So don't be surprised if you get, when you call the MAP Link number, some simple information assistance over the phone and get routed to your local MAP, who really is the expert and can help connect you with more supportive services, so they can come alongside of you and help with the application process and understanding who you need to contact and where you need to park and what mailbox you need to put an application in. They really can kind of help with those very minute details and really connect individuals to services and supports. One of the primary functions of Maryland Access Point, outside of connecting individuals to long-term services and supports and helping people understand the full range of services and supports that exist, is connecting people to Medicaid waiver programs and services. Many of you may already know, and we did touch on this very, very briefly in my last presentation, that the Community Options Waiver is not currently accepting applications at this time from anybody living in the community. So if you as a family caregiver are providing care to an individual who needs assistance, who may be eligible for waiver, the first point of contact to get on the wait list to be invited to apply for community options waiver is Maryland Access Point. Maryland Access Point does what is called a level 1 screen. Level 1 screen is only completed at this time by Maryland Access Point staff, and it is how individuals are prioritized and added to the community options waiver registry or the wait list to be invited to apply for waiver services. Waiver services open up the door to a wide variety of services and supports that can really help you as a family caregiver keep your loved ones safe and in the community, at home, and helping meeting their person-centered needs. It provides supportive services like assisted living care, adult medical day care, training for you as a family caregiver, case management services from a supports planner. You can gain access to Senior Center Plus, which is a program that is sort of like Adult Day, but a lesser restrictive environment. And it is for individuals who don't meet the medical criteria for Adult Medical Day, but are unable to attend senior centers independently. So Senior Center Plus is a really great option that provides meals and medication management on top of lots of educational programs and things. And it is a waiver program. You can get nutrition services and behavioral consultations. It also opens up, if you are eligible for community options waiver, you are also eligible for all of the services afforded through community first choice services. When Maryland Access Point staff are doing a level 1 screen, in addition to helping to prioritize the wait list for community options waiver, they're also looking at potential eligibility for community first choice. So if you've never reached out to Maryland Access Point and had a level 1 screen done, I would highly encourage that you do that, have a level 1 screen done on your loved one. That level 1 screen is the first step in connecting to all of the resources and services that you see on the screen. And all of these things are available to come alongside of you as the family caregiver and make your job a little less burdensome, a little more manageable in the day-to-day. It is important to note that eligibility guidelines for the community options waiver and waiver programs still have to be met, and eligibility is not determined by the Maryland Department of Aging. It's determined by the Maryland Department of Health. Gaining access to these services does not happen fast. There are currently 23,000 individuals on the waiver registry or on the wait list for these services. The Maryland Department of Health invites approximately 600 people each month to apply. Once individuals apply, there is an extensive eligibility determination process that takes place. From the time of application to the time services are implemented, it can take anywhere from 1 year to 2 years before services are being implemented. So don't delay, reach out, start that process as soon as possible. If you are in the community and you are eligible for community first choice, you do gain access to services slightly faster, but the eligibility criteria is a little more rigorous, and you have to be Medicaid eligible in order to access that program. The other important thing to note, and we get questions about this a lot at the Department of Aging, at each of our local MAP sites, people call all the time, are there any programs in the state that will pay individuals to be caregivers? Community options waiver and waiver programs may be able to pay individuals as caregivers or care providers. So if you are providing care for a loved one and your loved one is potentially eligible for community first choice or is invited to apply and is determined eligible for the community options waiver, then you may be eligible to receive payment for providing care for your loved one. There are steps that you need to take in order to do that you would work with the supports planner that gets assigned to your loved one to meet. As an example, you would need to work with a provider currently in the state of Maryland to receive some training, and they would then manage sort of the tax information and payroll and all of that for your care, and provide you some training on how to submit timesheets and things of that nature. So it's a little more detailed, but it's certainly a doable process. The waiver services are potentially going to switch in the next year or so to person-centered services, and that whole process may look a little different, just to kind of give you guys a heads up. Some of the other programs that you can access by reaching out to Maryland Access Point include senior care. Senior care is a really great program for individuals who don't qualify for Medicaid. So if you are not eligible for Medicaid, you're above the income threshold and you are not able to access the community options waiver, you're denied for that, you're not eligible for community first choice, senior care may in fact be an option for you. Senior care provides many of the same services that you see through waiver, things like personal care and chore services, medication management, adult day programs, respite for family caregivers, home delivered meals and transportation, as well as personal emergency response systems. Some of our counties do allow a more person-directed care model, and individuals through this particular program can be identified. So family caregivers can be identified as the care provider and be paid through this program as well. That is not true in every county. So, that one is a county by county situation. And if you want to learn more information, you would need to reach out to your local Maryland Access Point office. Currently in the state of Maryland, the senior care program also does have eligibility criteria that individuals have to meet in order to access this program. Individuals who are making less than $4,112.50 per month may be eligible. Married couples who make less than $4,700 per month may be eligible for this program. There's also an asset or means test associated with the eligibility, and individuals must have less than $11,000 in assets, and married couples less than $14,000 in assets. That eligibility criteria or scale does go up or change as Medicare increases and your benefits increase. So even if you've been denied senior care in the past, you may be eligible. So reach out to Maryland Access Point, especially if you're close, on an annual basis to determine potential eligibility. The other important point to make with this particular program is there may be wait lists associated with this program in your community. This is a state-funded program, so the funds for this particular program comes directly from Governor Moore's budget to support this program. And the allocations or the funding is split up across the entire state based on census information, as well as the number of individuals who need care in the communities across our area agencies on aging network. So in some areas, there's a greater need than funding will allow to serve immediately. So you may face wait lists for this particular program as well. Another really great program that you can access by reaching out through Maryland Access Point is a senior assisted living subsidy program. This is a program that is aimed at helping individuals who need assisted living care but are unable to pay for that care independently. Assisted living, as you well know, can be incredibly expensive and is not necessarily something that most individuals are interested in paying for out of pocket. And they look for oftentimes a lot of support in paying for assisted living. The assisted living subsidy program provides access to licensed assisted living facilities for individuals who are unable to afford the cost of a facility. Individuals who are eligible for the senior assisted living subsidy may find themselves, if they didn't have this program, in a skilled nursing facility without that support and assistance. The subsidy supports the cost of services provided in the assisted living, which includes things like meals and personal care and 24-hour supervision for individuals. In order to be eligible for the subsidy, individuals must be over the age of 62 and a resident in a facility or approved for entrance into a facility that participates with the program. So not all assisted livings participate with the senior assisted living subsidy program. To learn about the facilities that do participate in your area, to start the application process, and to see if there are any wait lists for this program in your community, you would reach out through Maryland Access Point. Maryland Access Point is the front door, as I said, and the access to accessing many of the area agency on aging programs that exist across our state network. The long-term care ombudsman program is always something that I feel like is important that we highlight when we're giving these presentations, because many of you may have had your loved one at one point in an assisted living or a skilled nursing facility, and we're not satisfied with that care. And that's why you've brought, them back home or back into the community and are providing such intense care. The long-term care ombudsman program is really aimed at helping to advocate for residents' rights, to ensure that individuals who are living in a skilled nursing facility or an assisted living facility have someone who can advocate and help them resolve issues that they might be up against while they're in those facilities. They provide education to inform residents and families and facility staff on a variety of issues related to aging and long-term care and resident rights. They provide information and referral to help individuals who are in an assisted living or a skilled nursing facility to resolve concerns or complaints on their own behalf. They provide consultation services and make recommendations for protecting the rights of residents and improving their care and quality. These individuals are embedded in our area agencies on aging. This is a state-run program that is funded through the Older Americans Act, and it provides a connection for family to reach out to advocate for their loved one. These individuals are in the facilities, in the community, and have relationships with the facilities in their communities to really provide that support that's necessary. So should your loved one find themselves in an assisted living or in a skilled nursing facility and you're unsatisfied with their care, or they are unsatisfied with their care, the long-term care ombudsman can help advocate for change and advocate that resident rights are being met. It's a really great program. And it is a program that is offered, as I said, in tandem with our area agencies on aging across the state. The State Health Insurance Program, or SHIP, provides information, assistance, and connection to Medicare programs and services like Medicare savings programs, and does annual drug plan reviews to make sure the prescription drug plan that individuals are on through their Medicare is the most cost effective. Why does that matter, and how does that relate to family caregiving? Oftentimes through SHIP, the SHIP program, SHIP counselors who are trained to provide Medicare counseling services and supports can evaluate or help you look at the Medicare situation of your loved one and ensure that they are in the right plans to save them the most amount of money, that if they're eligible for savings programs like qualified Medicare beneficiary, which would pay for a portion of the medical expenses as well as the Medicare Part B premium. If they're eligible for it, they can help them apply and put those funds back into your loved one's pocket that they then could provide additional personal care or privately pay for some of the things that they might need, and really helps to reduce out-of-pocket expenses associated with Medicare. There are also several, in many of our jurisdictions, several Medicare Advantage plans that are beginning to offer supplemental services. So reaching out to the SHIP office through MAP or reaching out to SHIP directly, you can learn about the Medicare Advantage plans that exist in your community that your loved one may be able to take advantage of that might offer some supplemental services like personal care, or groceries, a food budget, or I've seen some that have offered vision and dental and things of that nature to help reduce out-of-pocket expenses. So it's a really great resource to keep in your back pocket. On an annual basis during Medicare open enrollment, SHIP counselors are heavily involved in helping individuals evaluate their prescription drug plans to make sure that all of the medications that your loved one is taking are covered by the insurance and the costs associated with those prescriptions are as low as they possibly can be. So it's a really great resource to help put more money back in the pockets of your loved ones, or even to help offset the cost of continued care or even to supplement care to support you as the family caregiver. I did talk about this program during my last presentation as well. Just like to highlight it. I think this is a really great program. And it is a program that I think could save many of us some blood, sweat, and tears. There's a lot of assistive technology out there, a lot of assistive devices out there that can really make life as a caregiver a little bit easier. And the Maryland DME, or Durable Medical Equipment Reuse Program, has access to many of those devices at no cost for anyone across the state of Maryland. This particular program is a free in, free out program, which means that everything that we receive is donated to us. It goes back out to the community at no cost to anyone, regardless of injury, illness, disability, age. They have shower chairs, they have wheelchairs, they have motorized scooters, they have Hoyer lifts, they have a ton of things available. If there is a piece of equipment that could help make your life as a family caregiver just a little bit easier, because your loved one could more easily transfer from, outside of the tub or into the tub, or go from the sitting to standing position, or, get in and out of bed using that Hoyer lift. This equipment is available to you at no cost. You can learn more by calling the number that you see on the screen or visiting the website. There is a simple application process, and there are distribution sites all over the state of Maryland. While our main warehouse is centrally located in Maryland, you can pick up equipment from most counties across our state. So even pick up or drop off of the durable medical equipment is very convenient, or we try to make it as convenient as possible. One of the things that we didn't talk about the last time that I did a presentation was about some of the additional supportive services and services that are embedded through the National Family Caregiver Support Program. Some of those programs include support groups for family caregivers specific to dementia care, or grandparents caring for their grandchildren, or family care providers in general. There are many support groups available through our area agency on aging network and embedded in our senior centers across the state. This task of being a family caregiver can oftentimes feel very heavy, very burdensome, and very lonely. You feel as though maybe you're the only one in this, and support groups can really help dispel a lot of that. Each of our area agencies on aging and senior centers have a different offering of support groups. Some of them have many support groups to choose from, and some of our more smaller jurisdictions, maybe not as many, but certainly reach out to either MAP, Maryland Access Point, to learn about the support groups available through your area agency on aging in the senior center network, or reach out to your area agency on aging directly. You can also gain access to a wide variety of educational programs specific for family caregivers. Many of those programs are offered in partnership with Living Well Center for Excellence, which is one of the state partners, as well as partners with each of our area agencies on aging to provide classes virtually through their state hub network, which is a really great network of providers and trained facilitators that bring these evidence-based programs to life here in Maryland. There's a program called Powerful Tools for Caregivers, and that particular program is really aimed at giving family caregivers tools to better manage the day-to-day role that they're in, and improve satisfaction and reduce burden and stress, which is really incredibly valuable. Same with building better caregivers. There's a program called Chronic Disease Self-Management. There are lots of you that are providing care for individuals who are struggling with chronic disease, and you yourself may not necessarily understand all the ways to better manage chronic disease in the community. We are all oftentimes struggling with some sort of chronic condition, depression, anxiety, stress, all considered a chronic disease. Chronic disease self-management is a very empowering workshop that helps us better understand ourselves and how to manage our health in the community more successfully. There's programs called dealing with dementia or SADI caregivers, and lots of other evidence-based programs related to like nutrition and falls prevention and safety in the home. There are educational programs offered through the area agencies on aging and senior center network for almost anything. So if you haven't already connected with your senior center, I would highly, again, encourage you to do that, to tap into that educational network. Many of these programs may even offer respite so that you may attend fully. So somebody could come and sit with your loved one if they're unable to be left alone, and you can attend either virtually or in person some of these classes. So, it may not even necessarily be a barrier for you in attending. Through the National Family Caregiver Support Program, respite is a primary focus as well, helping you as a family caregiver practice self-care. As you know, caregiving is not easy. It's not for you as the caregiver and not for the person that receives care. The ongoing demands of caring for someone can put a strain on anyone. And that's why it's critical for caregivers to ask for help and to take a break when they need it. We're not good at that oftentimes, but there are programs available to support you. Respite care provides short-term relief for primary caregivers, giving them a time to rest or to travel or to spend time with other family members and friends. The care may last anywhere from a few hours to several weeks at a time, depending on what it's necessary for. And respite care can take place in a variety of settings. So you can have somebody come in and provide respite in your home, through a healthcare facility, an assisted living or skilled nursing facility for a short-term stay to give you the respite that you need or to take care of your needs, or even at an adult day center throughout the day so that your loved one has, one who is able to look out for them to make sure that they're getting their meals and their medications are taken care of during the day so that you can take care of things that you need to maintain your own health. Some of the respite services available through the National Family Caregivers Program in connection with the area agencies on aging and accessible through Maryland Access Point offer respite in the form of hours allocated to you or funding allocated to you as the family caregiver to give to someone else to come in and sit with your loved one, or funding to attend an adult day program for a couple of days a week or a couple of hours a month to just give you that opportunity to step away, to rest, like the guy in this picture. And as a family caregiver, how many of you actually felt like you've been rested like this particular gentleman in the picture? He looks like he's having a really great nap. In order to access the National Family Caregiver Support Program, you do have to be over the age of 60. So this particular program is for individuals caring for older adults over the age of 60, or for older adults caring for a loved one of any age. So, if you as a grandparent over the age of 60 are providing care for a grandchild or a disabled child who is under 60, you are still eligible for this program. And it is a program that varies from county to county and what it looks like. In some of our counties, you may be required to work with a licensed provider to provide respite. In other counties, the funds are allocated to you directly to use as you see fit to get the rest that you need, to the respite services that you need. There are also a couple of programs available through the local departments of social services. A lifespan respite program is available through the Department of Social Services that can provide respite on an ongoing basis to individuals who are in need of that. There is also an emergency respite service program, which is a one-time grant per year of up to $500 for individuals who have an urgent need. And when you connect through your local Department of Social Services for emergency respite, you can get access to services typically within a 24-hour turnaround. So if you're having a medical emergency and you need somebody immediately, there's not a long process or a long delayed wait time to get your loved one the care that they need so that you can get the medical attention that you absolutely need. And of course, there is also the National Respite Locator service available online that can help connect you to private pay respite opportunities across your community. It's really important to recognize that self-care in the form of respite is not selfish. You taking advantage of these programs that are oftentimes some of the programs that we see family caregivers turning away, saying, I don't need it as much as somebody else. You know, these are not selfish programs. You taking the time to step away to take care of yourself is vitally important so that you can continue to care for others. You can't pour from an empty cup. And if you're not taking care of your healthcare needs, who's going to be there when you're in the hospital, or if something, God forbid, were to happen to you to care for your loved one. So it's really important for you to take the time to take care of yourself while providing care, and respite services can really help you do that. Some of the other supplemental services that are available through the National Family Caregivers Program are personal care services, oftentimes through skilled providers or licensed providers that can assist with things like bathing and dressing and toileting and medication management. Homemaker services, which are non-skilled providers, often, they can be connected to licensed providers that can come into your home and provide assistance with cleaning and laundry and light meal preparation. Chore services that provide more specialized services like snow removal, lawn maintenance, tree removal, carpet cleaning, clearing gutters, all of those big tasks that you just can't seem to get to because you yourself are bogged down in the day-to-day of providing family care. And of course, your loved one is unable to support and complete these tasks as well. There may be services available through the Area Agency on Aging network that can support this through the National Family Caregivers Program. Many of the area agencies on aging also offer some transportation assistance. It looks different in every community. So if you need a support with transport to a medical appointment, or you want to go to the senior center for a class with your loved one and you're unable to get there yourself, there are also transportation services available that can support that. Sometimes it's in the form of a bus or taxi voucher. Sometimes it's a direct ride to medical appointments or grocery stores or non-medical appointments. In order to learn about all of the different programs that exist in your community that fall under the supplemental services through National Family Caregivers, the first point of contact is Maryland Access Point. Maryland Access Point is going to do an intake and some initial assessment and ask you lots of questions to really get to the root of, what are your needs and how we can create a plan together with you and your loved one to best meet those needs. So we can help look at your loved one as well as yourself as individuals, and then, create a plan of support for both of you in your home, in the community, to address the needs that you may have and better support you as the family caregiver in the process. I just wanted to remind everybody on the call today, if you're providing care, you're not alone. We're here to help you. The Maryland Department of Aging is working to increase services that are offered statewide to support those living with dementia by creating a dementia care navigation program. We're working to increase screening and assessment and add additional supportive services and resources for you as the family caregiver, providing care to your loved ones. If you haven't already reached out to your local Maryland Access Point or Area Agency on Aging, I encourage you to do so. We look forward to learning how we can better help you and support you in the work that you're doing. And with that, I'm going to open it up to questions.
Thank you so much. And we have a lot of questions. Somebody actually private messaged me that we need to have an entire webinar dedicated to just you and the resources. But we do have about 20 questions in our little Q&A box here. So let's go ahead and start with those. MAP services are all based on income, or are there any that I heard at least one that wasn't income based? So if you can just differentiate between those that are and are not.
That's a great question. So MAP itself is a free service. So MAP provides information, assistance, and referral. It's not a direct service provision. So Maryland Access Point helps you understand all of the direct services that exist and helps connect you to those by helping you with completing applications or, picking up the phone and making that connection with you through three-way call with your virtual or in person, physically picking up that phone and making the connection to a physician's office or, helping you just determine next steps in gaining access to, a diagnosis or gaining access to information or gaining access to the different programs and services that I talked about. So Maryland Access Point is completely free. Many of the things that we talked about or that I talked about in the presentation are also at no cost to you, but there are some that have eligibility criteria. In order to qualify, you have to meet income and asset means or testing. So you have to be under a certain income and have less than a certain number of assets. The exception to that are the programs that are offered through the Older Americans Act. So those supplemental services that I was talking about, as well as the respite services, are available to anyone, regardless of income, over the age of 60, because they're through the Older Americans Act. And it's funded by the Older Americans Act. With the Older Americans Act, those funds are non-restrictive in that you do not have to have income or asset means or testing in order to participate in those. However, many of our jurisdictions, so many of our AAAs across the state have a tiering system based on income because the priority population are individuals who are low income. So, if there's no wait list, and there is an opportunity in your community to access those services regardless of what your income is as well.
And related to that, someone's asking whether or not there's any recognition in the state or any talk to recognize that income needs to be adjusted, that, we do live in a more expensive region. Is there any movement on that, do you know of?
It is definitely part of our conversation. So right now at the Maryland Department of Aging, we are engaging in what we're calling Longevity Ready Maryland. It's our 10-year state plan. And as part of that, we are starting to work on several work groups. And several of those work groups are aimed at looking at affordable housing in our state. Housing is an incredibly difficult thing to get, affordable housing. Affordable health care, absolutely. So we're looking at our workforce development and ways to reduce the cost of care associated with personal care services and chore services. We're looking at, reducing the cost of healthcare. Many of the mandates or many of the income and asset testing that goes along with, as an example, waiver, are federal guidelines, are based on federal guidelines. And it is certainly something as a state, we're very acutely aware that, it doesn't necessarily mean the individuals who are over income can afford to do all of this on their own. So it is something that we are regularly looking at and working to advocate for change from the Department of Aging standpoint. We work with the Department of Health, Department of Housing, so DHCD, and other various partners to really address some of these issues and introduce legislation as we are able. We now at the Maryland Department of Aging, for the first time in a very long time, have a legislative liaison who during this session was able to really help us be a part of the legislative process, and is already, legislation just ended, right? So she's already projecting, and we're working on introducing legislation and what that will look like for the next year as well, associated with potentially, as one example, of something that we're working towards or thinking about is, just simply looking at the asset tests associated with the Medicare savings programs in the state of Maryland. So that may be something that you hear in next legislative session, that we're really addressing that to reduce out-of-pocket expenses, to lessen the barriers to accessing some of these services.
Thank you. Two related questions about the wait list. Anne Lurie Hyman would like to know how long the wait list is. And then Lanny McCary writes, it's difficult to hear about all the offerings when the wait list is actually closed and no information on when it's going to open again. So, can I comment on that?
Yeah. So I'm assuming the wait list that we're talking about is associated specifically with waiver. It is always something that has been a source of contention, we'll put it that way, in the state of Maryland and actually across our nation. There are few dollars associated and more individuals in our communities that need the services than any state department is able to serve. The Medicaid waiver wait list currently has 23,000 individuals on that wait list. The wait list is prioritized based on need. So the one thing that I will encourage people to do, even though the wait list is long, you can absolutely ensure that your loved one is being moved up farther on the wait list by increasing the likelihood of increasing their priority. So the way that you would do that is updating their level 1 screen at a minimum on an annual basis. So reaching out to MAP annually to complete the level 1 screen again to increase their priority, because we know, as time goes, oftentimes people, their conditions deteriorate and their needs increase. So as needs increase or conditions deteriorate, I would encourage you to do another level 1 screen. Keep that up, because eventually they're going to get to that top priority list. The top priority list, priority group 1 individuals, are typically being invited to apply within 6 months. Some of the other wait lists that I reference are things associated like the senior assisted living subsidy, as well as senior care. Those two programs, again, are very finite amounts of funding. It varies from jurisdiction to jurisdiction. So I can't say, matter of factly, that even every jurisdiction has a wait list currently. There are several jurisdictions, there is no wait list, which is really encouraging. This year, and again, next year, there are additional funds being added to the senior care budget to address waitlist needs. So, the state government budget has, recognized the need for these services and increased additional funding to address the waitlist that exists. So, there is work being done to address these things.
Great, thank you.
Yeah.
I do want to give our listeners a 5-minute break before our next presentation starts. Amanda, would you stay on? There are about 20 questions still in the chat box, and maybe you could just go in and type some responses. 2, I'll ask of you. One person is asking, because this is recorded, they're wondering if they would be able to share it, if we could share it with your permission with them, so that they could share it to a group that they work with. And someone else is asking, normally we don't ask for the PowerPoints, we don't distribute those, but they're asking if we could have your PowerPoint, because it does have all these great state resources and more information about that. Would that be okay?
Absolutely, on both accounts, I would be happy to. And please feel free, my contact information is on the screen. Feel free to contact me as well. I'm happy to, if you have a group that you'd like me to talk to, I'd be happy to do that. If you want to talk through some issues or have some, some more in-depth questions that you'd like addressed, I'm happy to meet with you. So please feel free to reach out to me directly as well. And I'm happy to stay on and answer some questions on the chat.
Great, thank you. I appreciate that. Everyone will come back. I know it's a short turnaround, but just get up, stretch, maybe get a glass of water real quick. We'll come back in 3 minutes at 2 o'clock to start our second presentation. Thank you. All right, welcome back, everyone. Amanda, could you take down your PowerPoint so Sage can put hers up, please? Thank you. Okay, welcome back. We're going to move on to our second presentation. Our presenter is Sage Hart, a health insurance specialist within the Division of Healthcare Payment Models, who will present on the Guiding and Improved Dementia Experience Model, aka the GUIDE model, which is a new voluntary nationwide model for Medicare Part B providers from the Centers for Medicare and Medicaid Services. Ms. Sage is a GUIDE model co-lead within the Patient Care Models Group at the Centers for Medicare and Medicaid Services, Center for Medicare and Medicaid Innovation. Her full bio is in your program book. Welcome, Sage.
Great, thank you. And before I get started, I just want to make sure, Dan, can everyone see my screen? The slides look okay?
Yeah, everything's good. Volume's good. Thank you.
Perfect. All right. Well, thank you for having me here today. For almost 2 years now, I have been working on the development of the Guiding and Improved Dementia Experience Model, also called the GUIDE model. And I was particularly excited to share with Laura, I was particularly excited to speak with this group today because prior to moving to CMS to work on this model, I worked as a special needs planning and elder law attorney in Maryland for 10 years. And so I'm partial to Maryland, but I also saw in that role how dementia impacts individuals and their family members, the additional responsibilities that care partners take on in their roles, as well as the need for specific coordination related to dementia care. And I'm hopeful that through this model, the services that it offers, it will reach and improve access to some of the services I'll discuss today for individuals living in Maryland to supplement all the services that Amanda had discussed. So with that, I understand that we have a diverse group attending the webinar today. And so I'm going to provide a very high-level overview of the GUIDE model and touch on aspects that may impact care partners, individuals with dementia, as well as a variety of professionals. And at the end, I believe we'll open it up for questions as well. And I just want to note that, Amanda provided a great overview of a variety of services that are offered in Maryland. And this next half of the presentation, we're going to focus on just one program, the GUIDE model. So I hope you re-upped your coffee because we're going to get into some weeds related to this program. And before I jump into the program itself, knowing that there are care partners and community members on this webinar, I wanted to provide just some background on what the Center for Medicare and Medicaid Innovation is. It's also called the Innovation Center for short. And the Innovation Center was developed 14 years ago as part of the Centers for Medicare and Medicaid Services. So it's a federal agency that develops and tests new healthcare payment models with the goals of improving care and lowering costs. And to date, the Innovation Center has had numerous models that it's put forth, and they can be specific to certain conditions. Some models focus on certain types of providers, whereas others maybe focus on a certain type of community. And the GUIDE model was developed within the Innovation Center to focus on having certain types of providers who apply to the program to provide services specific to dementia care. And I just wanted to make that distinction. I think it is important following Amanda's presentation as the GUIDE isn't a permanent benefit yet. If we can show that it improves care, keeps costs stable, it may end up becoming a permanent benefit. But as of now, it's a model, it's a test that will be available, as I'll mention in a bit, for the next 8 years. And so with that, specific to the GUIDE model, the GUIDE model, as I mentioned, is a test within the Innovation Center that is looking at whether providing an alternative payment methodology for the participating dementia care programs or practitioners, as they are, to deliver a package of care management and coordination for individuals with dementia, education and support to their caregivers, and then guide respite services to Medicare beneficiaries with dementia reduces expenditures while enhancing quality of care. And we're going to look at whether these standardized services that we're providing reduces expenditures by taking a look at whether it prevents or delays long-term nursing home stays, seeing if Medicare and Medicaid can save costs through those expenses. And then we're also going to measure and test whether the model improves the quality of life for individuals with dementia and then reduces the burden and strain on their caregivers. The model itself, as I just mentioned, is an 8-year model, and we offered it in all states, DC and the US territories. And we're at the stage now that applicants have applied to be in the model, and we have selected certain providers to provide these services. And I can't speak specifics as we're still finalizing those details of who will participate. But I'm very hopeful and expect that there will be providers in Maryland offering the services that I'll describe later on in this webinar. The model performance period, so the date that these providers can start offering the services under the model begins on July 1st, 2024. So in about 1 month, certain providers in Maryland will be able to offer services through this guide model. And the program is currently scheduled to end on June 20th in the year 2032. So we have the next 8 years to provide and evaluate the services to see if it meets those goals that I had just discussed related to cost savings and improving the quality of care for individuals with dementia. The guide model is going to be offered through 2 tracks. And this relates to participants. So when a medical provider applied to participate in the model, CMS assigned that provider to one of these 2 tracks, an established program track and a new program track. And CMS assigned certain providers to the established program track to begin to provide services on July 1st. Those providers that we felt through the application were already providing dementia care services as described by the guide model. And then the new program track was intended to encourage providers that may not be providing this comprehensive set of services that the model had outlined, this 1-year pre-implementation period, as we're calling it, to have a year in which they can develop and build their program. And the new program track will begin to provide services in July 1st of 2025. And after the model starts on July 1st, we will be listing on our website a list of those providers in Maryland and across the country that will be providing services and in what track that they are providing the services in. And for the purpose of individuals with dementia, the track is of importance as it relates to the date that the provider may begin to provide services. So the model was designed to attract a range of Medicare Part B enrolled providers and practitioners with the expertise to establish a dementia care program and provide this ongoing care and support to individuals with dementia. Some examples would be of participants would be a standalone physician practice or practices that are part of a larger health system or ACO. And then practices that have been established as a hospice agency or home health agency, they could also participate by operating or establishing and operating a separate Medicare Part B enrolled service line under the Medicare Vision Fee Schedule. And I would like to highlight out of these requirements that I've listed on this slide, 3 of the requirements for participants. So again, participants being the medical providers providing this care to me that we received some questions on is first, the participant must meet the interdisciplinary care team, care delivery and training requirements of the guide model, which I'll review in more detail in a few minutes. They must also be able to provide services either virtually or in person, but they must have the ability to conduct an initial home visit in person for certain beneficiaries that have moderate to severe dementia. And our goal for this requirement was both to enable beneficiaries to direct their care if they're unable to go physically into an office to receive services, that they have the option to receive services and meet with their providers via telehealth or virtually if they wish to do so. The last requirement on here is also that the guide model is requiring that the providers that participate make available to eligible beneficiaries respite services in the beneficiary's home. And I saw a few questions and comments related to respite services during Amanda's presentation, and I will touch base on that a bit later. But the guide model does require these providers offer respite services to their beneficiaries, and the participant has to make respite services available in the beneficiary's home, and they have the option to arrange to have respite services also available through an adult day center or facility that can provide 24-hour care. And we offered the flexibility to have respite available in an adult day center or facility that can provide 24 care, just depending on what's available in the provider's area that they're able to arrange. As this is a national model, so we need to be flexible to our providers across the country. So those providers who are not able to deliver all of the services that are required into the model have the option to partner with other Medicare providers and suppliers or non-Medicare enrolled entities in order to deliver the required services. And we refer to these partners as partner organizations. And we require the participant to keep track, enter into contracts with these organizations, and to keep us updated through a roster on who they're partnering with to deliver services. And there are a variety of different ways that a participant in a partner organization can work together to deliver the services required under the model. And I've just provided one example here that we'll walk through. And that's a physician's practice, as shown in this diagram, will serve as the participant in this example. So they're the entity that applied to participate in the model. And they, in order to deliver the services that the model requires, have partnered with an occupational therapy practice, as well as a home health agency. And the home health agency in this example is the entity that would be providing the in-home respite services as required by the guide model. And to learn more about partnerships and how these entities may be formed, if you're interested, we created a specific fact sheet that's available on our website that provides more detailed information about this topic. All right, so we also have certain requirements for the individuals with dementia to receive services through this model. And there are outlines here on this slide. And that's first that and we refer to them as beneficiaries, but the individual must have dementia as confirmed by their physician, which we'll have a form that the physician fills out and submits to CMS to confirm that diagnosis. The individual must also be enrolled in Medicare Parts A and B. This is also, I've seen this referred to as original Medicare or traditional Medicare. In order for an individual to receive services from a provider under the guide model, again, they have to be enrolled in Medicare Parts A and B. So that means, conversely, if an individual is enrolled in a Medicare Advantage plan, unfortunately, they wouldn't be able to participate in this model. And then they also, looking at the other requirements, the individual can also not reside in a long-term nursing home. One of the things we're testing is whether or not the services under this model delays someone moving into a long-term nursing home permanently. And so we ask that the individuals with dementia reside in the community currently. They also cannot have elected the Medicare hospice benefit or be enrolled in a PACE program. I will note that in order to receive services under this program, there's not a means test. We are not looking at the income or assets for an individual to see if they're eligible for receiving services under the guide program. It would be available to any individuals who otherwise meet the requirements. as outlined on the slide. And as compared to some other models offered through the Innovation Center, the guide model is unique as all beneficiaries may join the model through what we call it voluntary alignment. And all that means is that an individual who wants to receive services through a participant may do so and they have to elect or consent to receive those services, just as if you would go to any medical provider and wish to receive services through their care. In order to receive services through a guide provider, you must go to the provider, indicate that you wish to receive services from them. And once you start receiving services from them, you always have the option to leave and direct where you receive your care. So once an individual, so what do I start with? Explain this, but once an individual indicates that they're interested in receiving services through a provider who's participating in the guide model, they will, the participant will submit a short form to CMS, which again confirms that the individual has a dementia diagnosis. And then they're going to provide on this form information about the stage of dementia that the individual has, based on certain tools we're asking the participants to use, as well as whether or not the beneficiary has a caregiver. And with that information, CMS will assign the beneficiaries to a certain tier, and there's 5 tiers that we have outlined, and they're outlined here on this slide. And the purpose of the tiers is both to ensure that the intensity of the care delivery services may reflect the need of the beneficiary, depending on their unique circumstances. And the care delivery services that I'll review in a few minutes, all providers must provide, but the intensity that they provide the services may increase depending on the complexity of the individual's dementia. And the tiers are also used for payment purposes. The CMS is providing a unique payment structure to the providers who are participating in this program, and that payment is reflected based on the tier that the individual is receiving services, or that the individual patient was placed. All right, so I've mentioned a few times, and I think I'll probably spend most of my discussion today on the next few slides, as the guide model is requiring a certain care delivery approach from the providers that are participating in this program. We're requiring that the providers provide a certain set of care delivery services, that the provider has a certain type of care team to offer these services to beneficiaries. And third, we're requiring that the provider ensures that their care team, or their care navigators that I'll discuss in a minute, goes through a standardized type of training specific to dementia before working with beneficiaries. I'm not going to touch on number 3 today. Happy to answer any questions, and I'm going to focus the next few slides on the first 2 criteria here, and that's the standardized care delivery services and the care team. So the guide model requires that the providers that are participating in the programs, the participants, have a care team in place to deliver the services that the model requires. And we're requiring that there is a care navigator on the care team, and then also a clinician that has dementia proficiency, as we've defined that term as a dementia proficiency for the purposes of this model, has a specific term or definition. And we're looking at the clinician has past experience or an expertise related to working with individuals with dementia or older adults. As it relates to so in addition to these 2 roles, a care navigator and a clinician with dementia proficiency, those are the only 2 roles that the model is requiring, but we encourage our participants, of course, and we have seen on our applications to participate in the model that participants are planning to have a more robust care team in place of different types of professionals with the specific types of expertise to deliver the care delivery services that I'll review on the next slide. The care navigator role is intended to be one of the central roles of providing the services in the model. The care navigator is an individual of really any professional background. We've seen community health workers, nurse practitioners, nurses, social workers, physician's assistants, all successfully serve in this care navigator role. And the intention of the care navigator is to be a primary point of contact for the beneficiaries who are receiving services from the care team and providing many of the required care delivery services as may be applicable to how the participant has structured their team. So as I mentioned, we are requiring participants to provide a standardized set of care delivery services, which we have outlined in the 9 domains listed here on this slide. I'm going to take a few minutes. I normally don't go through the details of each of these domains, but I'm going to today just to provide some more examples of the services that the guide model will offer. So first, we are requiring that the participant provides a comprehensive assessment to beneficiaries and their caregivers, if they have one. We've outlined in our documents certain topics that must be covered in the assessment, and it includes an in-home assessment in which the participant, either virtually or in person, visits the beneficiary's home and provides input or advice as needed on how the beneficiary may be able to continue to live at home or address any safety concerns, for example. The assessment also includes an assessment specific to the caregiver, meeting with the caregiver individually to get their feedback on what their needs are, what their goals may be, and their level of possible stress and burden in serving in this role. During that comprehensive assessment, the participants, the care team, and the beneficiary will work together to develop a written care plan, which outlines the beneficiary's goals and preferences and needs in participating in the guide model. As I mentioned earlier, the services outlined on the slide, we're requiring all participants that participate in the model to make these services available, but the beneficiary and their caregiver gets to direct and decide what services that they will ultimately receive based on their circumstances. We're also requiring that the care team makes available 24/7 access so that beneficiaries and their caregivers have a phone number that they can call to speak with either a member of the care team or otherwise a helpline 24 hours a day, 7 days a week, particularly in the in the evening hours is maybe helpful to avoid those emergent visits to the emergency room as sometimes feels needed, and to be able to provide direction that's unique to the beneficiaries and caregivers, given that they're already familiar with the care team. We're also requiring that the care team and specifically the care navigators provide ongoing monitoring and support to the beneficiary and their caregiver. And depending on the tier that a beneficiary is assigned, I mentioned those 5 tiers earlier. Depending on the tier that a beneficiary is assigned, the care navigators are required to check in a certain frequency back with the beneficiary and their caregiver, just to check in and to see how they're doing and how they're progressing with the goals that are outlined in the care plan. And of course, at any time, the beneficiary and caregiver can reach out to the care team. It's just that we're asking that the care navigators initiate contact at certain times on a certain interval. We're also requiring that care navigators provide referral and support coordination. And so this is the type of coordination related to the recognizing whether or not the beneficiary and their caregiver needs assistance with other community supports, and then directing or making referrals to those community-based services and supports. So for example, if the beneficiary or caregiver needs assistance with transportation, We're asking that the care navigators have an expertise or background on what type of transportation services are available in Maryland, and then connecting the beneficiary and caregiver to those services. The guide model is not requiring that the care team provides the actual transportation service, for example. It's often a question that we get. Related to that, we're also asking that care navigators and the care team assist in the coordination of medical care. We recognize that their individuals with dementia may have other types of diagnosis as well, and it's important to coordinate the medical care related to those different specialties, as well as the transition from leaving the hospital or a skilled nursing facility back home. Ensuring that the care navigator is available to assist in those transitions as well. I'm going to skip respite services for now. I'll come to that at the end. I'm going to move forward to medication management. We are requiring that participants in the program review and reconcile medication as needed. And then in terms of caregiver education and support, we are requiring that participants make available for aspects for a caregiver support program. And that is that the participant must make available a caregiver training course, and they can partner with other entities. Some of them I saw that Amanda had reviewed to provide those services. They must be able to provide information specific to the beneficiary's specific dementia diagnosis. As part of the caregiver program, the participant must be available for ad hoc support calls, for example, through the 24/7 access. And they also must make available either referral or offer themselves a caregiver support group program for the caregiver, should they wish to participate. And the last service on here, and I put it to last, I know I saw some questions and comments in Amanda's presentation, is that the guide model is requiring that the participant makes available respite services to the beneficiaries that participate in this model. Again, as I mentioned initially, we're requiring that they provide the services, respite services, in the beneficiary's home, and they have the option to also make available respite services via an adult day center or a facility that can provide 24-hour care. So the model has set up the payment mechanisms to pay participants to provide respite in these three areas, and then the participant chooses what they can pull together depending on their circumstances. The respite services will only be available to beneficiaries in the model that are in the moderate or severe dementia diagnosis tiers, as well as the program provides respite services up to a cap of $2,500 a year. So there is a limitation on the amount that's available through the model. Financial limitations, once that financial cap is met for each beneficiary, they would have to wait until the following year to be able to access the respite services through the guide model. So I always think an example of what it would look like to participate in a program generally is helpful. And then this is an example specific to the guide model. So I just reviewed the variety of services that the model requires, as well as the type of care team that must be available to provide these services. And this is an example that's going to tie together those elements of the model. So in this example, we have Margaret, who was diagnosed with Alzheimer's disease 2 years ago, and her daughter Kathy is her primary care partner. Margaret's generally unsure how to access support, and her primary care physician referred her to a provider who was participating in the guide program. And when Margaret first meets with the participant in the program, as I mentioned earlier, she receives a comprehensive assessment and also sits down with the care team to develop a care plan specific to her circumstances. And in this case, Margaret had concerns walking safely down the stairs in her home. And that's an issue that she works with the care team to address, and they formalize a plan that they will include in the care plan. The care navigator that's assigned to work with Margaret checks in on her monthly. And the care navigator also reaches out and communicates with Kathy to address issues with sundowning, specific to Margaret's circumstances to assist with those concerns. The care navigator also works with Margaret on medication management. The physician on the care team reviews and reconciles the medications Margaret's retaking. And then the care navigator also provides Margaret with tips to help maintain her correct medication schedule. And then lastly, in this example, the care navigator works with Margaret to identify what other types of community-based services that may be helpful for her circumstances. And the care navigator refers Margaret to community-based organizations that may be able to help her identify or receive those community-based services. So the next few slides that I have relate specifically, or how do I put this? They may be of more interest to participants or providers in Maryland than our community members, but I'll go ahead and review some of these here. And that is that the payment methodology for this model. When I say payment, I'm referring to what CMS will pay or reimburse the participants in this model. I'd mentioned previously, as it relates to beneficiaries, individuals who are receiving services through this program, there's not a means test, so we're not going to look at income or assets to see if a beneficiary is eligible for the program. And we have also waived cost sharing for this program. So for many types of, maybe like all Medicare Part B services that you receive, there's often a 20% deductible that you have to pay as related to receiving that Medicare Part B service. And in creating this model, we have waived that cost sharing. And so if an individual receives services through the model, any of the 9 services that I had just reviewed, there is no cost sharing. There's no out-of-pocket costs for the individual to receive those services. But again, so this slide relates to how CMS will reimburse the provider, the participant, for providing the services under the model. This is not part of the Medicare physician fee schedule. It's not a fee-for-service program. We are going to reimburse providers through a per beneficiary per month payment. So each of the 5 tiers that I reviewed has a certain payment amount assigned to that tier, and every beneficiary that's assigned to that participant will receive the monthly payment in those months that they provided care delivery service to the beneficiary. The per month per beneficiary payment we refer to as a dementia care management payment. That will be adjusted based on the participant's performance. So based on how the participant does in certain tools that we're measuring them on, based on how they do on those tools, their monthly payment per beneficiary may go up or may go down a bit. And we're also adjusting, we also have a health equity adjustment that will increase or decrease the amount of the dementia care management payment based on health equity aspects that we're looking at. So the dementia care management payment pays for 8 of the domains of the care delivery services that I had reviewed. And separate from that, we have a separate payment structure specific to respite services. And I had mentioned that the guide model covers respite up to an annual cap of $2,500 per beneficiary. And it will reimburse participants for providing services with a certain dollar amount set on the type of respite that's provided, whether or not it's in the patient's home, in a adult day center, or in a facility that can provide 24-hour care. Each of those types of areas has a different payment amount, and a participant can provide and a beneficiary can receive under the model respite up to that certain annual amount. The model, as a side note, I'll briefly touch on, we're also making a payment, we're calling it the infrastructure payment. Applicants or participants, when they applied for the program, they had the opportunity to apply and be evaluated to see if they met the requirements to be qualified as what we're calling a guide safety net provider. They have that status. They were eligible to receive an upfront infrastructure payment to help develop and get their programs in place. And the infrastructure funds that are being released through this payment can only be spent on hiring, training of staff, the development of their dementia care program. They can also spend the funds on community outreach and engagement, as well as putting in place their electronic health record technology adaptations as needed. So not every applicant will receive an infrastructure payment, but it was one of the payment structures we offered in order to encourage participants to develop these programs. We are also going to require, in order to evaluate the model to see if it's meeting the goals that we've set, we're requiring that the participants in the model report information back to CMS. So we can both ensure that they're actually delivering the services that we're requiring, as well as to see how they're meeting the goals that we've put in place as we test this model. And then lastly, the model, we've put these requirements in place. We've developed a program, but we're also going to support participants through learning and activities. We've put in place for the life of the model a virtual learning platform, for example, where the different participants across the country can connect to learn and communicate with each other, to share ideas. We're also going to put out, we refer to as technical assistance, but fact sheets, webinars, educational information to support participants. And these will also capture and share just different strategies related to dementia care, with the goal of having the participants providing services through this program, delivering the best and most up-to-date care that is out there. So the timeline, I touched on it briefly, the two timeline tracks. This may be that's not out of date, but it covers a lot of what we've done in the past. So we had announced the model in July of 2023. We opened the application period. Participants have applied to the model. We've notified those applicants that were selected to participate. And right now we're in the stage right before model start. I'm so excited to be here, in which we are waiting for applicants to decide and to finalize their paperwork on if they want to move forward and participate in the model. As I think I mentioned from the start, we will be putting on the guide model website a list of those participants across the country who will be providing these services, and that will include the providers in Maryland that wish to do so. If you wish to learn more about the guide model, we have a listserv you can sign up for. It's on our website. You can also email us through the help desk. The guide model website includes some fact sheets that provides more information generally about the model. And if you really want to get in the weeds of what I've shared today, we also post on our website what we refer to as a request for applications. And it outlines the specific requirements and rules and what CMS will provide in the model. And it's meant for those participants to review. But if you wish to take a look at it, really provides some great details on what our goals for the model are and what we are going to require. And so with that, I'll leave this up. I think this has some helpful information, but I'm going to open it up and I welcome any questions.
Wonderful. Thank you so much for all this great information. We do have some questions. So let me start with Barbara Hillard asks, she's wondering if it's too late to become a provider in the study. So is it too late to join to put in an application?
It is. That period has closed. I do encourage anyone who is interested in participating in the model. There's always the option to partner and work with a provider that may have been selected to participate in the model. But at this time, we do not have any current application periods currently open.
What do you anticipate being the application cycle? Is it going to open annually, or do you kind of look at what's happening and then decide?
Yeah, we currently don't have another application cycle planned. I can't say it won't ever happen, but we currently don't have plans to open another one.
Right, thank you. Let's see, the next question is from Lori Hyman. What are the incentives for physicians and other service providers to participate in the guide model?
We have a fact sheet on that, the participant incentive fact sheet, which will probably provide more answers than I will provide here. So I encourage you to check out that fact sheet. Generally, the payment structure, we have built it to incentivize those participants or providers that are performing well on the metrics that we're using, that they will receive higher payment than they may otherwise through trying to provide these services through the Medicare fee schedule.
And then Carla has a couple of different questions. First, she's asking whether care navigator and dementia proficient clinicians can be the same person. How does a provider get selected or participate? And how do you provide services virtually in the guide model?
Okay. To be selected to participate, we had a formalized application that providers had to submit and return, and that we looked at through a TEP panel. In terms of I'm gonna have to ask you to repeat the first one. In terms of the providing services virtually, we have designed the model so that most of the services, is not almost all of them, except for that initial in-home visit for certain beneficiaries, can be provided via telehealth or over the phone, if that's what the beneficiary wishes to receive their services through. And what was the first question, Diane?
Whether the care navigator and dementia proficient clinician can be the same.
I have not been asked that question yet, so that's a very good question. I would say no. And in the examples or the models that we have seen, given the time that goes into serving as a care navigator, may not be most efficient to structure the program in that way. I don't know. Actually, if that's a specific example that you'd like more information on, please email the team. We could be open to that. But we would need both of those roles to be filled.
And then we have two different people asking kind of the same question or alluding to the same concern. Liz says, so many that could benefit from the model, but so few providers trained in the specific needs of geriatric patient. And that was my initial reaction too, as I'm listening to this. I'm like, where is the gerontologist? Where's the gerontology and geriatric education as part of this? And then related to that, James Sanders is writing, Jim is writing, workforce shortages is such a challenge in healthcare. Is there support to building and supporting the workforce?
Yes, and this was a topic that I had specifically looked into, gosh, probably over a year or so now. And I think those two points that you made are a little bit in tension, both that there's a shortage in the workforce, but also such a need for the training to encourage more expertise in this area. And so we had we've done a few things. One is we will require that care navigators receive certain training, so that the frontline individuals that are a contact point for the beneficiary must receive certain training in order to provide those services. And the goal of that requirement was to encourage some training and expertise and development in this area. We're also going to be providing through the learning system some educational materials for participants as a whole, related specifically to the model, as well as providing dementia care more generally. So trying to get the most up-to-date information out there through the learning system. And then lastly, we have required that there's a clinician with dementia proficiency involved in the model, so that hopefully the clinician there is a clinician on the team that has the expertise to oversee the quality of care and the services that are delivered to them, all to lend that expertise. But we did struggle with balancing that there is a shortage in the workforce. And so, we would hope a gerontologist would fit in the model in that mold. But we also want to try to encourage or just the interest in the model through the learning systems as well.
Great, thank you. And then Pamela is wondering how patients and their families find out what providers are participating in the model before July 2025.
We're not releasing that information. Actually, no, it's July of 2024.
Okay.
Or the summer of July of 2024 is when the model will start. And after that date, we will release the participants that are participating in the model. And if you want to, there's a listserv you can sign up on. I'm sure we'll put the blast on the listserv that we've posted this information on our website.
Thank you. And if you want to go ahead and send me or send Laura how to sign up for that listserv.
Yeah.
I think what we're going to do is update our booklet just a little bit. Someone's asking whether the links that you have, that you're showing right here, if we can put if they can be put into the chat. So I think what we'll do also is if you want to put those into the chat, you can, but we'll update our program book with this information as well. So we won't share your slide deck as part of the program, but we'll update the resource book so that everyone has this.
Yeah, and let me see if I can, just as I'm on chat now, I'm gonna put the website for the guide model in the chat, and that has links to everything else that's on this page.
Okay, great, thank you. That looks like all the questions. Poor Amanda, she's been very, very busy for the last hour answering a lot of different questions for her. So Amanda, we really do have to have you back for an entire 2 or 3 hour session by yourself. Sage, thank you so much. The guide model, I've heard of it. The Department of Aging has shared some information with me about it, but I didn't know a lot about it. So I really appreciate you taking time here on a holiday weekend. Everybody's excited for the long weekend. So, we had a lot of participants, Amanda and Sage. We are so grateful for the two of you to be here. So Amanda, did you get through all of your questions, or is there any other? Go
I
ahead.
still have 2 in the list that I'm working on right now. So if you haven't gotten an answer from me, hang tight. I'll get it in the next moment or 2.
Okay, anything you want to just say orally instead of verbally, or instead of writing it?
I think one of the biggest things I saw as a repetitive theme, or just around the number of wait lists and the challenges associated with accessing the programs that exist in the state network. And everybody is absolutely right. These programs are aimed to serve, and we promote these programs, but it's not always the easiest thing for people to access. The network of services and supports that exist in the state are incredibly complex to begin with, and that's sort of the role of Maryland Access Point, to help people understand the network of services and supports that exist, to better help streamline the access process and application process. But then with wait lists and the time it takes for eligibility determination and supports planning to be approved and reviewed, and it can be incredibly complex and a very long time before services are implemented. And what I would highly encourage those of you who are providers, or in this work, providing services to your loved ones and want to advocate, we are starting a wide variety of work groups to help influence our 10-year plan, the Longevity Ready Maryland plan that I was talking about. It's our 10-year strategic plan that is going to guide the Department of Aging and the services and supports that we will be offering over the next 10 years, and kind of give us our marching orders, our next steps. And if you want to be involved in that advocacy and participate in work groups, we are happy to have you, participate fully and inform the work that we're doing. So if you have ideas and suggestions, or you want to lend a new perspective to the work that we're doing, please reach out directly to me. I'll put my contact information in the chat as well. I think it's probably been there several times, but I am happy to connect you to the right person or to the right work group so that your voice can be heard.
Thank you.
Yeah, absolutely.
Lots of very positive comments in the chat box. So if you haven't seen them, take a look. Tremendous speakers. That's what people are saying. So thank you both for joining us. And thank you everyone who's attending today, but most of you have attended nearly all of our sessions. So we are so grateful to your participation.